term malrotation refers to the condition in which the midgut remains unfixed and suspended to a narrow-based mesentery. In embryology, 3 stages of development of the midgut are recognized. Stage 1, the first stage occurs during the 4th to 11th week of gestation. The midgut is forced out into the physiologic hernia within the umbilical cord. I'm so sorry, there's some words not clear. Stage 2 occurs at the 11th or 10th to the 12th week of gestation, during which the midgut migrates back into the abdomen. The stage 3, during the 12th week of gestation, the various parts of the mesentery and posterior parietal peritoneum fuse, notably in the right paracolic gutter, consequence of the error of normal rotation. Errors may occur at any one of the 3 stages with varying consequence. Stage 1, failure of the intestine to return into the abdomen, resulting in the formation of the exomphalus and omphalocele. Stage 2, during this stage, a number of the errors could occur. Non-rotation. Rotation may fail to occur following re-entry of the midgut into the abdomen. Incomplete rotation, which is the counterclockwise rotation, is arrested at 180 degree. The cecum lies in the subhepatic position in the right hypochondria. The duodenojejunal rotation is similar arrested, and the duodenojejunal flexure lies in the right of the midline. 3. Reversed rotation. The final 180 degree rotation occurs in the clockwise direction, with the colon coming to lie posterior to the duodenum and superior mesenteric vessels. Hyperrotation. Rotation continues through the 360 degree or more, so that the cecum comes to rest in the region of the splenic flexure in the left hypochondria. The encapsulated small intestine, a vascular sac which forms the lining of the extra-embryonic coelom, returns to mass into the abdomen with the intestine. The most common error is incomplete rotation. Stage 3, rotation occurs normally, but fixation defects result in the mobile cecum. Associated abnormalities. Developmental abnormalities of the midgut rotation and fixation are the predictable when the intestine is malpositioned at the patricium, omphalocele, the gastrochiasis, and congenital diaphragmatic hernia. Omphalocele hernia in the umbilicus, the gastrochiasis the absence of part of abdominal wall defect. Other important associations are intestinal atresia, imperforated anus, cardiac anomalies, and Down syndrome. Incidence of malrotation may go undetected throughout the life. 50 to 75% of the patients with the malrotation who become symptomatic do so in the first month of life. Approximately 90% of the clinical symptoms occur in the children younger than 1 year of age. The clinical presentation of the neonatal period: acute strangulating obstruction, acute life-threatening strangulating intestinal obstruction occur as a result of the midgut volvulus. The infant presented in the shocked and collapsed state with bilious vomiting, abdominal distension, or abdominal tenderness, with or without distension, and the passage of the dark blood rectally. Edema and erythema of the anterior abdominal wall develops as the volvulus becomes complicated by intestinal gangrene, perforation, and peritonitis. Subacute intestinal obstruction. Recurrent episodes of subacute intestinal obstruction are usually forwarding to the volvulus. The only sign may be bile-stained vomiting. Infant and children. Duodenal obstruction is most commonly the result of extrinsic compression from the lats peritoneal bands. The most common symptoms is intermittent vomiting, which is occasionally bile-stained. Failure to thrive or malnutrition. Older children may present with feature of the anorexia nervosa. Early satiety or the pain associated with intake of food resulting in the reluctance to end food aversion. Diagnosis: the clinical manifestation, plain abdominal X-ray, clinical early plain abdominal radiograph finding of the malrotation with volvulus ardus of the distended stomach and proximal duodenum with hypocity of the air in the distal small bowel. In the infant presenting in shock with feature of the acute strangulating obstruction. No need for the further investigation. Upper GI contrast study. Typically malrotation with volvulus produce an incomplete obstruction of the descent or distal duodenum with appearance of the extrinsic compression and torsion. Variably described as the bird's beak, the corkscrew, or the coiled appearance. The duodenal junction is not normally located. The usual position is left of the midline, rising to approximately the level of the pylorus and fixed wool posterior. Rather, it is anterior, low and often midline, or to the right of the midline. The small bowel is to the right of the midline, and the colon and cecum on the left. The treatment: neonates and infants with the rotated abnormalities require operative management due to the risk of the volvulus, which lead to the strangulation. Patients presenting with acute strangulating obstruction require rapid resuscitation before Proceeding to the surgery, this compress, rapid IV volume replacement, plasma 20 milli per kg body weight, nasogastric decompression, correction of the electrolyte and acid-base balance, post-spectrum antibiotic, correction of the hypothermia. Then, after resuscitation, proceed to the surgery. Laparotomy is preferred via the upper abdominal transverse incision in infant and midline in the children. Upper abdomen transverse in infant and midline in the children. Relieve the volvulus by the counterclockwise rotation. In patients with intestinal gangrene resection with end-to-end anastomosis. Lat band, folds of the peritoneum extending from the cecum and ascending colon across the duodenum to the right paracolic gutter and to the liver and gallbladder. Carefully divided. This operation is called Lat's operation.